my distinct pleasure and honor today as one of the co-chairs of the Lifespan IPC at Mailman Center, and Shelley Bear is on the call also, the other co-chair, to introduce our grand round speaker today, who we had the honor of actually hearing in the seminar that our IPC participated in and convened last autumn. And this is a return appearance now for Dr. Dolly Ferraiolo, who is a social worker by educational background and has her PhD in sexology, but her career is really tied into the problems that sometimes mental health people confront as they're growing up with their other kinds of developmental disabilities, especially autism. Her title of the presentation today is Framing the Landscape: Autism Across the Lifespan, from Early Patterns to Adult Mental Health Needs. And so we're very pleased that she has taken time out of her busy practice schedule to join us today for the Mailman Center Grand Rounds. Dr. Dolly?
Hi, everyone. Thank you so much for having me. Can everyone hear me okay? See the screen okay? I am getting over one heck of a cold, so if I mute myself, it's just to cough, not in your ears, so thanks for that. I'm so excited to be here today. Thank you for having me. I am Dr. Dolly Marie Ferriola. I am a licensed clinical social worker. Oh, sorry, I can't see anyone here. So if you need, if you have any questions, feel free to put them in the chat, and I know someone will ask towards the end of the presentation. So I'm a licensed clinical social worker. I'm a board certified sex therapist, and I hold my PhD in clinical sexology. I am super excited to be here today. My background definitely bridges trauma, sexuality, and neurodiversity. I definitely work with a lot of autistic folks. I am an autistic professional myself, so I do bring both lived experience and a clinical perspective to this work today. So today we're going to be exploring autism across the lifespan, but most importantly, how these early patterns shape mental health outcomes in adulthood, so we could be better, stronger practitioners. So today's learning objectives. Our goals today, we're going to be first identifying how autistic traits and patterns emerge across the lifespan. This includes early development through adulthood. We're going to be examining the common barriers to accurate diagnosis and also effective mental health care across our disciplines. I know we have a lot of different disciplines here today. And finally, we're going to be focusing on application. So what can we actually do differently in our workplaces starting today, starting the second we end this call? So it's important to remember that being practitioners is not just about awareness, right? It's about changing how we're showing up every day for our clients. It's about transformation through understanding. So that's really what today is about. So get out your notebooks. Feel free to take some notes along the way. Feel free to jot down any questions that you might have. This will be an open discussion. I will make sure to leave about 15 minutes or so towards the end of today's presentation so that we can talk about how we can utilize these strategies in our different environments. So setting the stage, right? We have innovation and connection. So it is really important to remember that innovation in therapy, it isn't about like new applications or great worksheets and all that fun, sparkly stuff that we like to utilize in our clinical settings. It's about connection. It's like the simplest way to build rapport, right? It's the most innovative thing that we can offer our clients. When our clients, or patients, especially autistic adults, enter the therapeutic setting, right, we're often made to feel misunderstood or overanalyzed. So true innovation is when we design our practice around who the autistic person is, not what we assume them to be, not what we see on TV or in the movies, right? Today's conversation is all about, like I said, reframing. So we're moving away from just basic awareness. We've gotten lots of great awareness over the years, right? Now we're moving towards authentic connection, right? We're here to understand the systems that either help or hinder our autistic and generally neurodivergent clients. So understanding the adult autism and across the lifespan, the landscape of autism across the lifespan, it's really important. But before we get into the bigger picture here, it's really important to remember that autism is not the linear line that a lot of us have been educated to believe, right? A lot of people believe that we have like high functioning on one side, low functioning on the other, and then all the different flavors of autism in between, mild, hot, spicy, whatever you want to say, right? It's really important to remember that it's that like autism is actually not a line. It's more like a pizza pie. We have like a wheel, right? So it's important to get away from functionality labels, especially when we're communicating with our autistic clients and patients. Saying high functioning or low functioning, it really does tell an autistic client that their struggle is not as important or as heavy as maybe their autistic peer next to them, right? So when we're talking about the pizza pie, we're essentially examining all the different kinds of domains that we can see when it comes to the autistic experience, right? So we have like social difficulties, stemming, sensory, sensitivities, anxieties, fixed special interests. Like these are all different aspects of being autistic. And every autistic person, regardless of functionality, will struggle to some degree in that pizza pie in some way, right? So every autistic person has these symptoms, right? But when we're talking about functionality, we're not saying that someone's high functioning in terms of their ability to work and walk through a neurotypical life. We're literally saying that they're verbal and they're making the neurotypical person's life easier. They're better able to make a neurotypical life easier. So that might mean that a high functioning autistic person, such as myself, right? I'm making eye contact right now. I'm able to like do this for you right now, be present, communicate clearly in a tangible way. I'm able to make eye contact. I'm still autistic, but what you don't see is internally, I'm manually processing how to do that. And it does create a lot of discomfort. And that pulls extra energy from me than, say, a neurotypical person who doesn't think about eye contact in that way or doesn't even have those kinds of things cross their mind at all throughout the day. So a low functioning person, quote unquote, will be someone who's probably not verbal or who does require a lot of significant supports in some way. So when we're talking about functionality labels, we're talking about support needs, right? There are plenty of times where me as a high functioning autistic person, I am disabled. If I go to a concert, for instance, I'm definitely going to be disabled. I have to utilize different accommodations. I have special types of earplugs. I usually don't get to stay the whole time because I hit my limit. So there are points in time where I will be disabled and other points in time where I'm not disabled. So as we continue working through this discussion, it's important to remember that functionality, it's very unique to the autistic person. It's always important to just ask them specifically the areas that they struggle with and to the length and severity that they struggle with those things. So that's a very big concept and a really big topic in the autistic community. Ooh, so sorry, I'm cutting through. So if you want to talk more about this, please write your questions in the chat. We'll make sure to get to that at the end of the conversation today. So some other details. Right now, there is an estimated 2.2% of U.S. adults identifying as autistic or diagnosed as autistic in the United States. I do know that there is a very political conversation around this right now. This is not a political conversation today. We are speaking about battery of tests and changes in assessments. So there has been an increase in those who are being diagnosed autism as autistic in the United States. And that's just because our conversation around it is changing. Our access to understanding autism is changing. And our ability to understand the deficits from past studies and past assessments is definitely changing as well. So this is technically a positive thing. We're seeing the surge because a lot of women and non-binary individuals and gender diverse individuals did spend a considerable amount of years being misdiagnosed with different things like anxiety, bipolar disorder, personality disorders, and we're definitely going to talk more about this in a few minutes. So it's important to remember that the system that we're faced with right now, it is still largely designed for children. Once an autistic person hits 18, there's not a lot of resources or accommodations that are available publicly for autistic folks. So we are diagnosing much more in adulthood, and that there's a gap there. So it is important to recognize that if we're able to catch our diagnoses much sooner, then we're able to provide a lot more accommodations at a time in a child's life where we can intervene and maybe change the trajectory when it comes to long-term outcomes. So if you are a pediatrician or you're a school social worker maybe, or you're ever working with young folks in any capacity in the healthcare field, keep an eye out when it comes to not just the common known symptoms of autism, but dive in head first and learn what some of the other less common symptoms of autism might look like, and how that might look across the lifespan, across different types of genders and backgrounds as well. So we've definitely touched on this quite a bit already. We will not have an autistic adult in this neurotypical world without having some co-occurring condition of some kind. It's impossible. Well, maybe not impossible. I personally haven't seen the research or been able to meet anyone who was lucky enough to just be autistic. So the reason for this is because, the world is set up to accommodate largely neurotypical people, allistic people. So when we're saying neurotypical or allistic, we're saying an individual whose brain operates at what has been determined to be the norm. So when we're thinking about autistic brains and so neurodivergent brains and neurotypical brains, I want you to think about computers, right? We have a Microsoft Windows and we have Apple Mac computers. Both computers, both can do all the same things, right? They just process very different, right? They get to the end goal in a very different way using different systems. So that's exactly what I want you to think when you are exploring autism and the different types of neurotypes that you might interact with depending on your background and workplace. So with that said, growing up as an autistic person in a non-autistic world, there's going to be a lot of issues with that, right? We have a higher rate of depression, much higher rate of anxiety disorders, definitely higher rates of trauma and processing challenges. You will definitely see a large number of autistic people also diagnosed with ADHD and executive function differences. If you have ADHD, you're not necessarily autistic, but if you're autistic, you probably largely will probably also have ADHD. And in the world, we call it ADHD. I have ADHD. So that's just the fun combination of having the chaos of ADHD and the rigidity of autism put together. So that makes for a very colorful and exciting life, let me tell you. But there's also other co-occurring conditions such as OCD, obsessive compulsive disorder, definitely some food-related disorders that you'll see running amok in the autistic community, right? So I would definitely say ARFID. So that's it's a sensory-related eating disorder. A lot of restrictive rigidity when it comes to ARFID. Of course, anorexia you'll see a lot. You will also see a lot of queer folks, LGBTQ plus folks who will also be neurodivergent. It's just a common intersection there. And they will also struggle a lot with gender dysphoria, and that ties into higher rates of PTSD. So it is really important to remember that if you are operating with maybe someone who might present with a lot of anxiety or maybe some social anxiety and things like that, maybe think about the differential diagnosis there. Maybe there might be some autism under the surface that we need to be exploring, because a lot of the times if we start diagnosing somebody with a lot of different things, a lot of the times the simplest answer is usually the right answer, right? Maybe we're not all of this stuff. Maybe we're just autistic or have maybe a couple of related conditions related to that. But with the right supports, we can feel a lot less depressed, a lot less anxious, a lot more in control. So it is important to keep in mind that you will have a lot of co-occurring disorders. These symptoms are not separate from being autistic, from autism. They're definitely often the response to chronic invalidation, sensory overload, years of masking, right? So when we're treating the symptoms without understanding like the root cause, then we are definitely, risking pathologizing our patients instead of meeting them where they're at. Want that. All right. So we're up against a lot here in the medical community. Fewer than 30% of autistic adults ever receive appropriate mental health support. Of these, 80% describe their experience as negative or even harmful. Unfortunately, we as clinicians don't often receive a lot of education in this area. I know myself in my MSW program, I remember talking about autism literally one day, I think for like 15 minutes or so. It was in my the psychopathology class when we were looking at the DSM and we were just literally reviewing it. So as we all know, the DSM, it's a great roadmap, but it's not the end all be all when it comes to really understanding the complexities of a lot of these different diagnoses. So, we definitely need to find it in the community, a bit more passion in the community when it comes to learning more about autism so that we can spot this much earlier so we can intervene and provide accommodations and provide relief before a child reaches adulthood. So we definitely have a high need population here trying to access a system that's just built for neurotypical children. So unfortunately, our workforce is largely unequipped to meet the needs of autistic children, and that's a systemic bottleneck. So if we can all work together across disciplines to support each other and try to spot symptoms much earlier, maybe provide more creative services in the community, working as a team, that can definitely help mitigate the issue leading into adulthood. So here's a fun quote, and I hear this a lot. Therapy always felt like a test I couldn't pass until someone finally spoke my language. So the reason why I put this quote in here is, like I said, I hear this so often from my autistic clients. I felt this myself as an autistic individual trying to navigate the healthcare field. But also, it's really hard for autistic people to advocate for themselves. From a very young age, given the fact that we are, operating in a very neurotypical world, we don't always know our truth until we know it. It takes us a long time to really find our center and what guides us because we're so used to having to adjust and reevaluate in the moment so that we are able to blend in, right? That is the definition of masking. So when we get to therapeutic settings, we don't even really know even what to talk about or what to say. We don't even know where to start half the time. So it is really important whether you're a therapist, whether you're, I'm saying therapy always felt like a test, but this also applies to, if you're in pediatrician's office, if you're working with a minor, or if you're a doctor communicating with someone you think is neurodivergent or someone who did disclose to you as neurodivergent. This applies to all types of healthcare settings and educational settings. So it's really important to remember that you have to meet your clients where they're at. It's a powerful reminder that our job, it isn't to change someone else's language or put our language on someone else. It's important to learn what they need, learn how they define things, learn where they struggle, and just remain trauma informed to understand that maybe an autistic client is holding back. And when I say maybe, that's probably quite likely. Most autistic clients are really unable to advocate for their needs. They've had a history of being told that they're too much or that their needs aren't valid, or honestly, not even realizing that the need is even there, right? If we operate our whole lives feeling and experiencing something a certain way, we don't even know that it's not that way. If we see the world and we see the sky is the color, purple, until someone tells us that it's blue, we think it's still purple. So, having more direct and assertive questions in your assessments is really helpful. Making sure that something isn't open-ended, like a question isn't open-ended, making sure that in your questions you're not using metaphors or allegories or anything like that. Like, you're being really, really direct and clear. You don't need to have any small talk. You're not making anyone feel uncomfortable, I promise. If anything, we're thankful for it. You can just get right down to business. And when you're asking about the body, just know ahead of time that an autistic person really does struggle with body cues, really does struggle with identifying the severity of things such as pain. So, a paper cut might feel like the end of the world to an autistic client, and a broken arm might feel like nothing. So really keep this in mind when you're operating with an autistic client, that we definitely need some extra assistance when it comes to self-advocacy and identification. Okay, so we'd have a quick little case reflection here. We have a 29-year-old woman diagnosed at 27. When she was a child, she was often described as too sensitive, overreactive, dramatic. Hear that a lot. Ended up getting late diagnosed autistic. Felt years of feeling corrected or misread in therapy. So her breakthrough came when a therapist co-created some written agendas with her, made sure to adjust the lighting in the office, gave her some permissions to stim, like just left like a little bowl of like stimming tools around, like just so she can feel comfortable kind of being herself in that environment. These were some super small changes, but they completely changed her sense of control and safety in the office environment. So why is this important? Right. So for autistic clients, control over our environment is emotional regulation. Right. So if you have an autistic client who's melting down, it's literally just because they're feeling probably unheard, unseen, misunderstood in some way. So if you can recognize that that's usually the core driving factor of that dysregulation, and you pause and just make some small changes or ask directly, can I adjust the lighting for you? Will that help? Do you need a snack? Will that help? Like offering direct options versus just asking, like, what do you need? It's like, we don't know what we need. Sometimes we need the environment to be set for us, and then we go, oh, okay, there we go. That's what we need. And now we can give you what you need, right? So it is really important to just try to have your autistic clients feel seen when it comes to their unique needs and accommodations. So what about this therapist approach built trust? I think this is a really important question to ask yourself, something you could sit with. What about these like little minor changes that probably meant nothing to the provider, probably meant everything to that client? How does that build trust with our autistic clients? How did that predictability and control foster safety for this autistic client? So you can put little answers in the chat if you want, or just kind of hang on to that and just reflect on that. But it is important to ask yourself, how do we build trust? Obviously, rapport building is number one. I know we've learned that ad nauseum in our classes, right? So when it comes to our autistic client, it's going to take a lot longer to build that rapport than a neurotypical client. So creating that sense of control and safety and predictability is probably the fastest way that you can get there. Okay, so diagnostic overshadowing. This happens when autistic traits get mislabeled as something else. And this is unfortunately so common. I would say probably every single one of my autistic, I can't think of an autistic client that I've had that's come to me for therapy who hasn't been diagnosed with something incorrect in the past in some way. Maybe not incorrect based off of how they were presenting at the time, but definitely not the correct diagnosis for them, right? So a client may, for instance, show a flat affect or avoid eye contact, but that doesn't necessarily mean that they're depressed or dissociating or something, right? Or have a personality disorder, right? They may have like sensory shutdowns that could be mistaken for emotional withdrawal, or meltdowns that are seen as defiance. We see this a lot with our minor clients, right? Get labeled with ODD a ton when in reality, they're just autistic, and they aren't getting their needs met in some way. And so they appear to be really defiant. Of course, then we have masking. So this is the attempt to hide autistic traits. Most of the time, autistic folks don't even realize that they're doing it. We don't realize we're doing it, right? Everybody masks to a degree. I think every single person can understand masking, the idea of that, right? Like, I can guarantee none of us are our true 100% true selves at like work, for instance, or maybe like around our grandparents, right? Like, we understand the concept of masking. We understand that we sometimes represent ourselves in altered ways that may not necessarily not be us, but it's still trying to assimilate in some way in the environment. Unfortunately for autistic folks from birth, right? Because to be autistic, like, you're born autistic, right? It's not something you develop. You can't take a Tylenol and become autistic. You are born that way. It is literally your neurotype. So if you are born a certain way, but then you see the world around you acting a certain way, and you yourself are not naturally acting that way, you do start kind of morphing into versions of yourself that you think the environment around you calls for. So this is a huge problem, right? Now we're having identity problems, suicidal ideation. This definitely leads to burnout because we're overextending ourselves in ways that we think we need to do in order to be well received, or just literally extending ourselves in the way that the world calls for. But because we are doing that, living our life in a way that's not set up for us, that then is taking more energy than the neurotypical peer next to us. So this can lead to a lot of issues when it comes to anxiety, depression, MDD type symptoms. So something to look out for as well, especially in our high function quote unquote clients. Any if you have like minor clients, for instance, who are very intelligent or gifted, especially female presenting, I would kind of just always have it in your screening to just check for those things, because more intelligent, like higher intelligent female presenting individuals often go under the radar for most of their life. I would say that's the demographic that's diagnosed later in life most often. So catch that sooner, right? And then they'll get the supports that they need. So when clinicians are recognizing autism for what it is, then we're moving from mislabeling to then understanding, right? That's the whole point of today. So recognizing, recognition itself becomes the treatment. So beyond diagnosis, we have daily frictions. These silently erode the therapeutic connection that we're trying to make with our clients, right? So we have sensory overload. These are things that happen in most clinical spaces, right? Harsh lighting, overhead lighting, loud HVAC systems, scents, right? You got a lot of candles or a lot of those like spritz scent things in your office. Just unpredictable stimuli in general can push anyone into fight or flight freeze before your appointment even begins. So step one, just creating a more inclusive environment, right? Communication mismatches. So many autistic adults and kids process language literally. So phrases like "let's unpack that" or like "how did that land for you?" Those are really confusing statements. So when you're speaking to minors as well, I would talk to them like little adults. Just be really clear and direct. I think that you'll probably get farther with them with that communication. And of course, the stigma. Even with neurodivergent communities, there's some invisibility. So, like we mentioned earlier, these terms like high functioning or low functioning, they're not describing ability; they're describing comfort levels for other people. So the takeaway here is, when we make the medical environment or the educational environment physically and linguistically safer, right? You get what you need. And that's the whole point, right? We're trying to have this back and forth connection with our clients. So when we show up and we make our adjustments that for us don't take too much effort, for our clients can make or break the relationship. So these are really simple things. So think about throughout the rest of this presentation what you could be doing a little bit differently in your workspace. So we have another little case reflection here. So we have a 32-year-old non-binary client. They said that therapy always felt like performing normal. So trying to predict what their therapist wanted them to say or what their clinician wanted them to say. So how do you catch when a client might be doing this? So think about this for a second. What are some ways that we can try to catch our clients from masking, from performing, right? We can utilize some reflection techniques. We can help them identify gaps in their understanding, especially when they might be trying to be normal in session or in the appointment. They might not even know they're doing it, right? Again, we all just want to be liked to a degree. So I think for an autistic person, we've been performing for so long that it does come quite naturally. So just kind of having that in the back of your mind, just knowing that this is something that will probably take place, especially at the start of building rapport with somebody. You just want to try to identify any gaps, try to challenge and reflect back as much as possible. And then maybe even using different types of educational supports, right? So, we can say things verbally. We can also utilize some visual supports, maybe some like literal language supports. In this situation, for the first time, this client felt seen and heard and started understanding the concepts in the session. So that's really exciting. What about this pivot from the therapist made this client feel heard? Is it just because they weren't talking at them? Was it because they were utilizing different types of accommodations to try to meet the client where they're at, right? Utilizing more than one learning style in your sessions or in your appointments, whatever environment you're in. This allows autistic people to just obtain the information in many different ways, right? We need time and space for processing. We need to make the sessions more accessible to the client. So a lot of the times, if you provide lots of different ways to understand the information, we could take it away, we can digest it, maybe we can follow up in writing via email with any questions, or maybe you have a worksheet that you can provide some feedback for, like the follow-up visit after that. Just important to remember that everyone's a little bit different. Everyone needs to learn a little bit differently. So these, if you are like a medical practitioner, for instance, and you're doing like those quick 15-minute sessions back to back, like I know, especially if you're like a nurse practitioner out there, or a doctor or pediatrician, we have to hit our productivity numbers. I get that. But if you just slow down a little bit and ask them to repeat things back to you, or just come prepared. If you already know a client's autistic, or asking that as part of the screening process, the intake process, just already preparing maybe some alternative or additional things that you can use in your appointments with them, that would be helpful. Okay, so every barrier that we've named has a potential breakthrough, right? So we have, when we are misunderstanding is just a mismatch, right? We want to think about coming at our clients with curiosity, with collaboration. We want to co-create structure with our clients and patients. Shift from feeling guarded to being open. That's what we want from our patients. So trying to engage our autistic clients in a way that gets them really excited for their care. We want them to be, like I said, curious. We'll shift them away from just complying to actually collaborating with you. So that's the whole point. We want to create curiosity, create connection. When we come to autistic clients, the rigidity is definitely a struggle a lot of the times. And, we definitely have some pathological demand avoidance from time to time. So that just means that if you want to get buy-in from your autistic client, that could probably, like if you're like an educational space, or maybe a pediatrician, or maybe an ABA therapist, you have a minor client and you're really struggling with that, or even our adult clients who have really rigid thinking and are really struggling with getting them to buy in. You have to figure out what works for that specific client. Once you get that excitement from them, once you get that enthusiasm, they'll start, once they get the why behind what they're doing, then you'll get the buy-in that you're really looking for. Okay, so we're going to anchor this in some practice. So there's 4 key pillars to autism affirming therapy. So we have strength-based. So we definitely want to focus on autonomy and sensory intelligence, not the deficits, right? We want to make sure we're building treatment plans about, around what regulates our clients, not what suppresses them. So just making sure to validate their differences and just focusing on finding the autonomy, right? Want to have a collaborative structure, right? Sharing written agendas together, using visual tools like we mentioned, co-creating treatment goals together. Like I mentioned, getting that buy-in is super important. Predictability will reduce your client's anxiety and will support their executive functioning and will get what you want out of them. So that's really important. Staying sensory informed. So, making sure that we're adjusting the environment, softer lighting, movement breaks, maybe controlling over the seating. Before we're labeling resistance, like make sure that your autistic client is and it has a calm body, like is processing what's going on in front of them. I think that providers are too quick to label rigidity and resistance when in reality there's just dysregulation there. And then, of course, flexible modalities, right? Being able to offer telehealth is really helpful, especially when we're struggling with agoraphobia, helping with, maybe some asynchronous messaging, maybe some art therapy, music being integrated into the sessions or appointments, excuse me, somatic work, just all evidence supported, more inclusive for sensory and communication needs. Excuse me. So again, predictability and choice from the foundation of psychological safety. This is important. You just want to create predictability, and that will create safety for your clients. All right, we have a third case reflection here. So we have a 27-year-old artist who I'd worked with and had spent many years just shutting down in talk therapy, right? We incorporated painting and guided movement. Then she began expressing emotions without her language. So through this process, we learned that for her, art became the translator for her between her body and her story. So, I'm not an art therapist, but I started, utilizing some craft-based things in our sessions, utilizing our movement, our bodies more. I realized that she had a lot of restlessness. And so that really helped her find her words, right? So, this case helps remind us that therapy, it's not limited to words. It's about creating access to self-expression, right? So for us clinicians, providers, what works in practice? So want to screen every client for autistic traits and sensory needs. Just have it part of the intake, right? You just a few basic questions, just kind of see, is this someone who might fall in that space that you might need to maybe do some additional screenings for? Always use literal, clear language and always summarize progress at the end of sessions. This is just helpful in general. I think anyone could really benefit from that. Co-writing agendas together so sessions have structure and flexibility. That could be very helpful for autistic folks. And normalizing stimming, movements, self-regulation behaviors, just letting your clients kind of move and do their own thing without making them feel like it's weird in any way, without calling it out in any way. And of course, ask for feedback. What's working? What isn't, right? You can always just say, I'm neurotypical. Or even if you are neurodiverse, we're all different, right? So we all have different flavors. So it's important to ask, how can I support you best? Do you need different kinds of lighting? Do you need, how's the smell in this place? Do you have a headache when you walk in here? What do you need from me to make this the most inclusive practice for you? And we want to build those competent environments at a systemic level. We need to design environments where competence is built in. It's not optional. We need to incorporate autism and neurodiversity education into onboarding and CEUs. Like today, you're all here today. Thank you. We need to offer sensory-friendly waiting rooms and adjustable lighting, like I mentioned. Also, partnerships. Hire consultants or panelists with lived experience. Thank you so much for having me here today because I'm able to speak through this experience, not just clinically, but also personally. Competent systems, we can't wait for clients to adapt to us. Like we have to adapt first, or we're not going to be able to meet them where they're at. So bigger picture, um, you know, we don't exist in a vacuum. Autistic people, we're not just like autistic in one place, and that's, where it is. We are gender diverse individuals that are diagnosed later and often misdiagnosed first. We're Black and Hispanic autistic adults who are more likely to face, disciplinary actions or criminalization pathways than mental health pathways. Autistic folks are queer autistic individuals who report higher rates of trauma and self-harm and suicidality. So these are all things to start talking as early as possible so we can provide the right structures, the right supports, the right accommodations, the right learning experiences for our younger autistic folks. And that way, when they age out, right, become 18 plus, they have all the supports that they need to be able to live life in a happy and healthy way. So, equity in care, it starts with designing for those at the intersections because, with inclusion, it works for everybody, inclusion's for everybody. So what does this mean across the disciplines, right? So we've already talked at length about this. We want to always make sure we're using that clear, literal communication, screening beyond just the presenting symptoms. So, there's online, you could find the RADs, RAD 7, RAD 14. I'm getting the numbers wrong, but there's a bunch of questions in there where you can pull some of those out and add those to your intake assessments, your screeners. You can also recognize sensory and communication differences before labeling behavior. That's a huge, huge thing. And also looking at all different types of environments. It's really important to think mindfully of your autistic clients and patients. Like, they may be presenting a certain kind of way in one environment, but is that consistent across all environments? Is that consistent across the whole lifespan? Maybe there's triggers that we're not noticing. Maybe there's certain things that we're not recognizing that, we make some very simple, small changes. And here we go. We're meeting our clients where they're at, and they're calm and regulated in their appointments, and we're able to really assist them with their needs, and they're able to just flourish, right? So we want to just make sure we're building these environments that reduce barriers for just expecting compliance from people, right? We want to make sure that they feel seen and heard so that you get that buy-in that you're looking for. So again, we want to assume neurodiversity from everybody, right? We're in a very neurotypical world. It'd be great if our healthcare providers, our educational providers just assumed everybody's neurodiverse. So everybody in the room is always neurodiverse. And if you're neurotypical, then that's great. Then you'll do fine with the accommodations regardless. But if you are neurodiverse, that's going to go a long way for them. You want to make sure you're always asking about sensory needs before starting any treatments of any kind. You want to make sure that you are utilizing those flexible communication options, visible and asynchronous messaging, emails, things like that. Just prioritizing autism training, communicating more about that through supervision and hiring processes. And then, replacing correction with curiosity always, right? Because it's, inclusion, it's not about just like that extra credit. It's just about, our ethical practice. We are the future of mental health here. We are here to help our clients. And it's really important that we, set the tone for our autistic clients and their needs. So any questions, feel free to drop some questions in the chat. If you have any specific questions, feel free to email me anytime. I have my email on here, our websites. So a little reflection prompt here. What is one small change that you can make in your practice this month? Okay. So that could be in your educational setting, your healthcare practice, what have you. Just think about that. And that's what I hope you take away from today's session. All right. Any questions?
Dr. Dolly, thank you so much. Dr. Dolly, that was terrific. Thank you so much. I always appreciate the clear communication style that you have and hearing the definitions and explanations of behaviors from your professional standpoint, but also your personal standpoint. I found that very helpful. I realized some housekeeping. There are some links in the chat for Mailman
Ooh.
Center programs and for other information about the Mailman Center that I forgot to say at the very beginning. And I'm not sure I even introduced myself as Larry Friedman and Professor of Pediatrics in the department at the University of Miami. So now, if there are questions, I have been monitoring the chat and I hadn't seen any in particular, but people can come off mute and ask questions of Dr. Dolly if they have any, or make comments.
I'm going to put my contact information in the chat as
There
well,
are
just so
some
you all can copy and
questions
paste.
now. There is a question, are there any studies to search that a participant can look deeper into the experiences of autistic adults?
So
resources
that's
or
definitely a loaded question. There are plenty of studies out there that do explore the experience of autistic adults, right? So there's a lot coming out now about ABA, and I definitely won't get into that. That's a very divisive topic, but there's plenty out there when it comes to ABA and the impacts of ABA therapy in childhood, and how that can lead to PTSD in adulthood. So there's a lot of studies around that. There's now an up and coming crop of studies around relationships, communication, sexuality, romantic connections. That is definitely my area of focus. I focus on helping autistic adults navigate communication, intimacy, relationships. That's my main focus. So I could definitely speak on that, but there isn't as much as we would like. I think that the last 5 to 10 years has been a huge increase in research, thankfully. But that's part of the bigger conversation here. This is why we are having a political conversation around autism right now. It's because a lot of the foundational research that is available was done solely on young boys, which is a very specific type of demographic, right? That's going to yield a very specific symptom set. So that's why we're having this huge surge of diagnoses right now for autistic folks in adulthood. It's because we're really expanding the knowledge and information around symptomology when it comes to different flavors, if you will, of autism. So I would definitely suggest starting with Google Scholar. It's free, it's out there. But if you also have access to your schools, if you are in school right now, I know, we have University of Miami here. So if you have access to that database, definitely just start searching keywords based off of some of the areas of interest or your specific background.
Austin or Rosaline, if you could post the Mailman Center links again for people who might have joined late. And I know now there are lots of good comments, Dr. Ferraiolo, in the chat on your presentation,
Dr.
and
Dolly's
how much people have learned and providing information to us all. There are specific questions from some practitioners who wanted specifics about how to treat certain things, and I don't know that we have time for that.
Well, I see a good question here. Any recommendations on how to tell that a young adult that they would have I'm so sorry. Any recommendations how to tell a young adult that they have autism traits and that they would benefit from a full evaluation? I feel the few times that I've brought it up with the stigma associated with autism, some of the young adults have different reactions. Okay, so this is really interesting. I think it definitely depends on the type of kid you're talking to. So you'll get two schools here, right? You have some kids who are very locked in on the internet, right? You get the TikTok kids they got all the great therapy words. They know exactly what you're talking about, and they might get really excited about what you're saying. And they may already have a pretty good foundation of understanding, and they might agree with you. And then you have some kids who just don't know what that means, and they're thinking that they're being othered in some way. So I think that this comes down to how we talk about it. So I would start with open-ended questions. If you've noticed some traits, let's just say like stimming, right? Like maybe you're noticing them stim a lot. You can just say like, hey, I noticed that sometimes when we're talking about really stressful topics, you rock back and forth a lot. Can you tell me how that makes you feel? Like, does that calm you down? Does that make you feel more anxious? Right? Like, so now you're starting to like have them open up about their experience, and they themselves can verbalize that conclusion along with you. And when you do introduce the topic of autism, it's only weird if we make it weird, right? Like if you say something like, "Hey, I notice these traits, and you might be autistic," like that's gonna probably feel a little bit weird. Versus, I notice these traits, and there's a lot more research out here now about being autistic, and that doesn't really mean anything different other than how we might talk, or how you might communicate, or how you might learn how to regulate yourself. So, like, if you just approach it in a more chill way, they're more likely to receive it in that way, and make it more interactive. Get them to reflect the why behind it. Like, okay, exploring this is going to be helpful because if I can get answers, then I know how to help myself. So that could be definitely helpful.
And we know of some teenagers and young adults that actually find a little relief when they get a
Yes.
diagnosis that then helps them to understand their presentation or
Yes.
behaviors or thoughts.
100%.
What other questions might people have in the remaining few minutes? There is a link also to the evaluation.
So I see here from Gregory, what would you like to see that would help further research into the experiences of autistic adults? Honestly, money. I would like to see more conversations around this. I think the questions are being asked, the interest is there. We just need the space, the time, the funding. So I would love to see any type of research that can help substantiate the need for accommodations and services for adults over the age of 18, right? Like for autistic people over the age of 18. Like I said earlier, a lot of the resources end at age 18. Most of the available services are for minors. So I think if we had more research that goes above and beyond just under 18, then maybe we can get the funding that we need for those kinds of social supports and services. Although I know that's kind of a tall order these days. So anyone else? Any other questions? Let's see if I missed any.
Jen Feinstein at the CARD in Miami has indicated that there are some studies on adult meltdown experiences.
Ooh, that's good. Love to share those.
And you see a lot of the good comments thanking you for presenting to us today. Oh,
Thank
and
you
there's
for
a
having me,
question.
everyone.
Okay. All right. And then there is a link now to Dr. Dolly's slides.
I'm going to send an updated version to you guys. I made some edits this morning.
We have a couple of minutes left if anyone has a question. Otherwise, it gives us a chance to fill out the evaluation.
Yay. No questions?
Well, we really look forward to hearing your words again, Dr. Dolly. And you have an interdisciplinary audience that I know learned a lot and hopefully will take some of your practical recommendations to heart.
Yeah, who do we have here in the chat? What do you got? Do we have any? Tell me your disciplines.
I know
What
we have
environments do you all work in?
MDs. I know we have
MDs.
MDs, social workers, speech and language pathologists,
Mm.
psychologists. Oh, they're all listed
Yeah.
now.
Yay.
Program managers, coordinators, parents,
Nice.
educators.
Awesome. Well, if you have, I know this is a very generalized presentation today. Again, just trying to speak to multiple environments, disciplines. So if you have any direct questions, feel free to email me. I love talking about this stuff. It is my special interest. So feel free. More than happy to answer any questions outside of here. Um, Especially if you're like a parent or educator, a clinician, just looking for different ways that you can support your autistic clients or just kind of meet them where they're at. More than happy to assist anytime. Save my info. Awesome.
And thank you, everyone, for participating today in the Mailman Center Grand Rounds for April.